Hi, I'm Surya Banerjee, a consultant microbiologist, and I've got an MCQ for you. So here it goes. We have a 24-year-old normally fit and well man who presented with sepsis to the accident and emergency. On examination, you find a cut with surrounding area of inflammation. GP prescribed flucloxacillin 2 days back, but the cellulitis is still spreading. He had a recent MRSS screen that is negative. His profession is a footballer. There is no history of travel, and he has a dog which might have licked his wound. So considering this history, what would be the antibiotic of choice? Your options are coamoxiclav, piperacillin tazobactam, meropenem, tigecycline, or cotrimoxazole. While you are thinking about the answers, we will go through a couple of slides about dog bite. Why dog bite? Because mouth flora from a licking wound and bite wound would be the same. So 90% of the animal bites are dog bites, and the bacteria that you normally expect from a dog bite wound are Pasteurella multocida, Capnocytophaga canimorsus, anaerobes, Staph aureus, and Streptococcus. So in this case, you might have think about Staph aureus, but whether it could be an MRSA, and that's why patient is not responding to flucloxacillin. Possible, but that's why there's a clue that he had a recent MRSA screen that is negative. So in these cases, we will concentrate on two bacteria, or any dog bite wound. You should think about two bacteria which are unique. These are Pasteurella multocida and Capnocytophaga canimorsus. So what's unique about these two bacteria? Pasteurella multocida, you can get it from many animal bites: dog bite, cat bite, camel bite, komodo bite, lion bite. If someone survive, you can get Pasteurella infection from them. There might not be a bite wound though. There might be history of leaks, and in quite a significant number of cases, about 1/3, you might not get a bite history or leak history at all, but you will get a pet history. So ask for pets, dogs, cats. In the exam, look for animals as pets. Gram-negative rod. It is a gram-negative rod, but it is penicillin sensitive. That is unique because most of the common gram-negative rods like E. coli, Klebsiella, they tend to be penicillin resistant. So penicillin sensitive is a clue. It doesn't grow on clade or McConkey agar. That will be another clue. The drug of choice in this case is coamoxiclav, and it's only unique about that is it presents with skin and soft tissue infection many times, but you should not use antibiotics which you normally give for cellulitis, for example flucloxacillin, or macrolides like erythromycin, clarithromycin, clindamycin, or first generation cephalosporin. There have been report of failure when using this antibiotic. Coamoxiclav is fine, Piptaz is fine, but you really do not need to go that broad. Coamoxiclav would be sufficient. What about Capnocytophaga? What are the clues? So you can get it from dog bite, cat scratch, so animal associated wounds. But what unique about this bacteria is that you most of the time or many times you get history of comorbidities like asplenia or alcohol excess. Look for these hints, asplenia especially. But also it might be an immunosuppressive suppression of some sort and diabetes. Patient usually present with septic shock or deep infection. They have fever and they often have disseminated intravascular coagulation. Again, these bacteria is a gram-negative rod, but they have like a fusiform set of shape or spindle shape. It doesn't grow on clade or McConkey agar. They are oxidase and catalase positive, and drug of choice is again coamoxiclav. This bacteria produces a lot of beta-lactamase, so it is easily able to break down antibiotics like amoxicillin or cephalosporins, so you should not use those. But you can use something which can combat the beta-lactamase or counteract the beta-lactamase like coamoxiclav, so clavulanic acid would help. Piptaz, tazobactam would help. You can use carbapenem, clindamycin, doxycycline, this kind of antibiotics as well. So answer to our question is coamoxiclav. Why not piperacillin tazobactam? Because it's broad spectrum and there is no history of pseudomonas, which is an advantage it has over coamoxiclav. So I don't want to use a broad spectrum antibiotic like piperacillin tazobactam or meropenem in this case. Tigecycline or cotrimoxazole are non-beta-lactam. So if I have an option of using beta-lactam, I will always go for beta-lactam antibiotics. So coamoxiclav would be my choice. Thank you.